The role of surgery in metastatic breast cancer, it is traditionally, as we know, that it is the first line of the treatment in the systemic therapy, and the surgery usually it is reserved for the patients for palliation of the symptoms like fungations and ulcerations and the bleeding. And there is no talk about the survival, or there is about the chest wall controlling. In the last decade, there's a lot of the retrospective studies that's been emerged mainly since 2000. These studies all are retrospectives, and about more than 300,000 patients being enrolled, and about 40 to 60% of these patients, they are involved in the surgery. And part of these retrospective studies, it shows that the association between the surgery for the primary tumor, it is associated already with the survival. And a part of these studies, it is giving the opposite, and they are saying there is no association between the surgery and with the survival, or there is an association not because of the impact of the surgery itself, it's because the selection bias for these patients. I have some papers that I presented now that it's showing there is an association between the surgery and the survival. But before I start that, I will talk what is being written on the papers about the advantages of the surgery for the primary tumor in the stage 4 breast cancer. First of all, it's improving the quality of life and function for the patient, reducing the hematogenous seeding from the primary tumor, eliminate the resistant cells by resection of the necrotic tumor, improve the disease response to the systemic therapy, and delay the progression of the disease by reducing the number of the circulating tumor cells, and potentially it's improving the prognosis. And last is less the harmful immunosuppressants from the tumor cells. A lot of data is being emerged showing the connections between the surgery and the survival. The first and the largest study, it's been published in 2002 by Dr. Sima Khan, and it is the largest databases involving about 16,000 patients who they are presenting from the 1990 up to the 1993. And in this study, they conclude that the women who are treated with surgical resection with the free margins, when compared with those not surgically treated, they have a superior prognosis, and they have a better survival. Another study in 2007 for 409 patients, also they conclude for the surgical patients, surgical excision of the primary tumor was associated with a significant longer survival in this cohort study. Another study also, it's been also giving the same conclusion that the surgical patient, for the 300 patients are involved, complete surgical excision of the primary tumor improved the survival of the patient with the metastatic breast cancer. But in other hand, there is another papers, still they are giving the opposite, and they didn't show any association between the surgery and the survival. And if there is an association, they are already put it for the selection bias, not because of the impact of the surgery itself. But before I start that, there is a theoretical talk about the surgery in a patient who they are stage 4. First, they are talking it's an invasive approach in a patient who they are no proof there is a connections between the surgery and the survival. Number 2, the main treatment is the systemic therapy, not because of the surgery. Third, it's because the surgery and the anesthesia, it is a trauma and can produce a cytokines that can compromise the integrity of the immune system. And the survival, it is already determined by the tumor burden cells, not because of the surgery itself. One of these studies, it's giving that from MD Anderson, they conclude that the removal of intact primary tumor of the breast cancer patients, it's improving only the progression-free survival, but there is no association with overall survival. Another study, they are seeing there is a survival in the patients who they are stage 4 with the surgery, not because of the surgery itself, but because of the selection of this patient with ER/PR positive and HER2 amplification is because of the targeted therapy, not because of the surgery. And the third, also another study, it's showing that there is a survival, not because of the surgery, is because of the selection bias. Eventually, All these data are a retrospective data. There is no clinical trial until a current moment. It shows there is connections or there is a relations between the surgery and the survival. But still we need a clinical trial that can answer our question, is there is a relation between the surgery and an overall survival? So a group of clinical trials start to be studying this subject. One of the studies from India and from Turkey, they already give the conclusion for these patients, and they show there is no relation between the surgery and an overall survival. But still there is a questions between in these clinical trials, and I will talk about it later, from the Indian trial. In the Tata Memorial Hospital in India, they are conducting a clinical trial since 2005 up to 2013, enrolling about 350 women with a stage 4 breast cancer. They're giving a course of anthracycline with or without a Taxan, then the patient going for surgery, stratify the patients for the site and the number of metastases and the hormonal receptor status, local regional therapy or there is no local regional therapy, and the endpoint was the time of progression and overall survival. Over 17 months for this trial, it shows there is no advantage for the surgery if you compare it for the systemic therapy alone. But still, it is not clear for this trial if the systemic therapy is being used before or after the randomization. And the patient who they have a HER2 amplification, did they use a targeted therapy for these patients? So it is not clear really for this study. A similar trial is being conducted in Turkey and it is giving the same, but those patients, they are starting the surgery, then they followed after that the systemic therapy. And these preliminary results, they are showing that there is no significant advantage for the surgery. There is a number of other clinical trials still conducting in United States and in Japan and in Netherlands. They are still recruiting the patients, but at the current moment, there is no prospective data. It is giving the advantage for the surgery over the non-surgical in the survival. In King Faisal Specialty Hospital, we conduct a retrospective study studying the role or the impact of the surgery on survival for the stage 4 breast cancer. I will talk about it just a little. In this algorithm, before I start in the surgical point of view, all patients with a stage 4, we are giving them a surgery, offer them a surgery. But before we start them, we are starting with induction of the systemic therapy. If the patient showing clinically and radiological complete response, we are intent to cure these patients, and we are doing for them complete local regional therapy by surgery and by radiation. In the other hand, the patient who shows there is partial or no response or progression of the disease, we intend to palliate these patients. We are doing just a local control by surgery plus or minus radiation. The method, it's a retrospective, it's a single institution, King Faisal. We recruit the patient from the 2001 up to 2011, about 678 patients with a stage 4 breast cancer. We put the baseline characteristic for the patient for tumor, metastasis, and the treatment. For the patient, we put the date of the diagnosis as a stage 4, or the breast cancer, sorry, and age of the patient, gender, menopausal status, performance status, and the last follow-up and the vital status as life, dead, or lost follow-up. The tumor size, subtype as an invasive ductal carcinoma or invasive lobular, histological grading, hormonal receptor and HER2 receptors, and lymph node status. Metastasis by the number as a single or multiple, and by the site by the bone or visceral. The treatment, systemic radiation and surgery. For the systemic, using anthracycline base and the Taxan base, hormonal and biological treatment. The exclusion from the study, if the patient have other primary tumor, we saw there's patient with a primary ovarian tumor or lymphoma, so we excluding them from the study. Other histological than invasive ductal or invasive lobular. Metastasis after surgery or metastasis after 3 months from diagnosis of breast cancer or unknown surgical status. Exclusion from the surgery, we are not offering surgery for the patient if not fit for the surgery or for anesthesia, if the life expectancy is less than 6 months, or unresectable disease. Indication of surgery, either to palliate the symptoms as a toilet to remove these ulcerations or fungation, or to prevent the patient to develop any local disease, or as a curative intent. The surgery we offer for the breast as a mastectomy or lumpectomy. Mainly lumpectomy, it is done for the patient who they are recruiting from outside of King Faisal, and for axillary dissection or no axillary dissection. The timing of the surgery, usually the surgery is performed after 4 to 6 weeks of the last dose of the palliative systemic therapy. The median surgical time was 3 months, as starting from the date of the diagnosis until the date of the surgery. This is the statistical method. The results. The total number is 678 patients. The surgical patient was about 61%. Non-surgical patient was 39%. The surgical patient who they are operated in King Faisal was 76%, and from outside it was 24%. This is the patient characteristics. If you notice here, for regarding the surgical and the non-surgical patients, commonly the patient, they are ranging onto the same age group from the 35 up to 55. They have almost the same age group. And for the menopausal, the surgical patients mainly, they are premenopausal if you compare it for the non-surgical patients, and it was statistically significant. The gender, it was similar in both. The performance status, it was better in the surgical patient if you compare it for the non-surgical patient. And the metastasis at presentation, which is the patient presenting to our institution with a proven that they have a metastasis, was significantly for the surgical patients. The patient who they are non-surgical, they have a more nodal involvement if you compare it to the surgical patients. The tumor size, the patient who they are non-surgically, if you notice here, it is about 80% with T4 if you compare it for the non-surgical patients to the surgical patients, who giving the tumor, it is more advanced in the non-surgical patients. And also, as I said, for the nodal involvement, it is more in the non-surgical patients. And for the proven that they have a metastasis at presentations is more for the surgical patients. The the non-surgical patient, they have a more soft tissue involvement, bone involvement, the liver and the brain involvement, but the lung, it was similar in both groups. Number of metastases, the number of metastases, single metastasis, it was more in the surgical patients, but the multiple metastasis was more in the non-surgical patients. In the single metastasis, it is almost like similar in both patients groups. The tumor size, it was smaller for the surgical patient if you compare it for the non-surgical patient. And the median size, it was 6 centimeters for surgical and 8 centimeters was for non-surgical patient, which is giving the tumor, it was bigger. Histologic, it was same. The surgical patient, they have a higher grade, which is grade 3. Interestingly, the surgical patient, they were more ER/PR negative than the non-surgical patients, but the HER2 was similar in both patient groups, and the triple negative was more in the surgical patients. Chemotherapy, also it was given mainly for the surgical patients than non-surgical, and also the biological or targeted therapy was more for the surgical patients. Hormonal therapy was more given to the non-surgical patients. Here is the conclusion. The total number 412 patients, the total number who they did mastectomy, it was 86%. Lumpectomy, it was 14%. The total number of axillary lymph node dissection was 64%, and about 36% we didn't offer for them an axillary dissection. Here is the end of the study. About the total patients who they are, we know about their vital status is about 530. About 178 it was alive, and 352 of the patient was dead. From alive patient, 28 from the surgical and about 24 from non-surgical patient, but it is not significantly for the both patient. The median survival for the surgical patient was 3.1 years, which is about 37 months, and about 1.9 years, which is about 22 months for the non-surgical patients. The 3-year survival rate was for the surgical was 51%, and it's about 34% for the 5-year survival rate for the surgical patients, which is giving more for the surgical patients. Here's an overall survival for the surgical if you compare it to the non-surgical patients, which is better, or it is on behalf of the surgery. If we talk or focus about the site of metastasis, the single metastasis, they have a better survival than the multiple metastasis. And if you're looking for a location for a single metastasis, the bony metastasis and visceral metastasis, there is no significant between the survival between both patients. For the palliative therapy, either before or after surgery, there is no differences in both patient groups. Overall survival for the patients who they are, if you're looking for the tumor biology, ER positive in surgical patients, they have a better survival than the patient who they are ER positive in the non-surgical patients. And for the triple positive in the surgical patients, also they have a better survival than a non-surgical patients. The triple negative, there is no differences in both patient groups. Here are the univariate Cox regression models. It shows here the surgery and the ER positive and radiotherapy. They are showing they have a better, the patient who they are offering for them a surgery and ER positive and radiotherapy, they have a better survival than the patients who they are a triple negative, or they have a larger size of tumor, or they have a metastasis at presentation. In a multivariate Cox regression, still the ER positive patients, they have a better patient who they have ER positive, they have a better survival than non-surgical. They have a better survival than the other patients. And the metastasis at presentation and the tumor size or bigger size of the tumor, they have worse survival than the other patient. And still the surgery, it is independent prognostic factors in these patients. After adjustment for these factors, for the surgical, non-surgical, and it shows there is a minimal differences from the adjusted and unadjusted graph, and still the surgical patients, they have a better survival than the non-surgical patients. If we're coming back again to the retrospective studies, we are keeping our study at the last, and it's almost showing what is written before. But because it is a retrospective in nature, and the selection bias, it is unavoidable. And still, we cannot guarantee that this advantage on the patient or they are a surgical group is due to the impact of the surgery itself. But still, the randomized control trial, it is needed to answer our question if this is because of the surgery itself or not. But still, we have recommendations. Our recommendation to offer the surgery for all patients with a stage 4, either as a curative intent to prevent this patient to die with a local disease, and as a palliative to give a quality for their lives.
Raising a question about and answer as well, because it's long session, we allow 2 questions for after every speaker. So if you have any questions for Dr. Abdel,
Actually, can I ask you something?
Yes.
So if I have metastatic breast cancer with a 2-centimeter lesion on the breast and 5 centimeters on the liver, which one should I take?
First, those patients who they are having a metastasis, I will offer for them this systemic therapy, and I will see the response after
No,
that.
if they get the systemic therapy, both have response. But the large mass is on the liver, the small mass on the breast.
And only a single mass?
Only a single mass. Which one should I take?
Usually we're giving, of course we are going for the primary tumor.
So, I'm sorry.
Because
I mean, how much I should argue should put after the bigger one, which then leaves the tumor and separate the tumor cell. I mean, if we have a control trial.
What is written that any metastatic single metastasis we are giving after systemic therapy, we are giving up to 1 year. After 1 year, then after that, after the surgery and after systemic therapy, and still is there that I can remove that only single metastasis.
Thank you for a very nice review. I think this retrospective data always I mean, perplexing and difficult to interpret. You probably selected your winner ahead of time. I mean, you've selected the one that have low tumor burden, selected the young, selected the good performance status, selected the one that have a good response, and you excluded all the other factors. So at the end, you've selected the one that you expected to win, and then you said that they perform better. This is always going to be, confounding factors, and we would never be relying in a retrospective data, which the biases is so clear from the start, isn't it?
True. Yes, that's what I said about the selection bias, and it is something unavoidable. If you go backward like 10 years, you cannot avoid. Still, the surgeon, he is selecting the patients who they have a better performance rather than the patient who they cannot go to under anesthesia. And we cannot offer the surgery for the patient who have the brain metastasis, because I know the life expectancy is less than 6 months. So you're right, and I'm with you, that this patient, they are very much selected. And the selection bias, I cannot exclude it, and it is unavoidable for all this retrospective data. That's why they are going into the clinical trial to prove that the patient who they have surgery, they have a better survival.
Which was not proven.
It's not proven until the current. There is
We
nothing
have
is
two-
proven. True.
We have 2 negative studies. I think, to give more weight to a retrospective against 2 randomized trials is something we have to be careful with. We do it sometimes. We do take the primary in certain, cases.
Yeah.
But I think we have more weight towards no effect.
True.
And we have to admit this.
True. What I said about the survival, but we offer the surgery for the patient is to give a quality for the life and to control the local symptoms. But regarding the survival, it is a controversy.
I agree.
Okay, thank you very much. Oh, yeah.
Thank you for your nice presentation. I want to ask about the value of axillary lymph node dissection in metastatic disease like this.
Yeah.
If I have just to do palliative surgery to mastectomy, what's the value? It is metastatic already. So I just give the patient increase the morbidity and the mortality of axillary lymph node dissection.
Yeah, thank you very much. Usually the patient who they are offered for them the surgery in the stage 4, we are starting into the palliative surgery or palliative systemic therapy, and we are seeing clinically and radiological response. If the patient showing clinical and radiological response, we are offer them a local and regional control by the mastectomy and the axillary dissections. If the patient doesn't show, or it is a partial response, or it is a progressive disease, we just do a mastectomy for them. We're not controlling for the axilla. Yes.
Can I ask why mastectomy? Why in even curative intent we go for wide local excision, and in metastatic setting you go for mastectomy? It does not make sense.
Usually because it is all the breast is diseased in those patients.
No, it's not true.
And
I mean, these assumptions I think has to stop.
yeah.
We go locally. We know from the local regional treatment that this is effective for cure. And yet we have a patient who has metastatic disease, and I'm not sure whether this is going really to affect his survival.
There is no contraindication for obesity as is it a small and you giving a negative margin.
In your study and others, all the surgeons always talk about mastectomy in this setting.
Yeah.
I need someone to convince me what's the logic.
First, I will have to guarantee for those patients, because most of the patients who they are presenting with the stage 4, they have a local disease. They have a locally as a T4 and the other.
Is it true?
Most of the patients they are presenting.
No, it's not. From when, again, we would like, this is not true.
But I'm.
Just I need to give it time. Thank you so much for
Thank
the
you.
great presentation.
Thank you very much.
All the questions are going to be done to Dr. Ahmed. So it's my pleasure now to present Dr. Ahmed Saad-Din, who's going to be talking to us about metastatic hormonal prostration. What is the recommendation? Dr. Ahmed Saad-Din is well known, but briefly graduated from King Faisal, then went to UK to obtain his clinical oncology, long experience in medical oncology, and huge contribution to the Saudi Oncology Society. Right now, he's a senior consultant in King Abdulaziz because of the International Guard. Dr. Ahmed.
Invitation, and I'm really enjoying the meeting and the discussion a lot. I think خلاف في الرأي لا يفسد للود قضية. So today I'm going to actually talk about what I consider an earthquake in breast cancer, the second earthquake. I think the first earthquake is the Herceptin story. We have all to maybe agree to that. And I think we are living the second one, which is related to the hormonal therapy of endocrine sensitive breast cancer. These are the issues I'm going to touch upon very quickly. And no matter how much we sometimes disagree on how to treat a patient, I think we should always maintain a teamwork, team effort spirit. I think, the more discussion you have, we all get better in the way we serve our patients. It's a common disease. I think endocrine-driven tumors, as you can see, breast and prostate are the leading causes of incidence and mortality in humans. What we know about breast cancer and we don't know about prostate cancer is that it's not one disease. It's actually many diseases, and this is a very sort of short summary of what we have. But what I'd like to share with you that almost 3/4 of the patients we see are endocrine sensitive tumors, ER positive. You see sometimes people talking about 55, others talking about 75, 80, and the reason for this difference is actually how do you define your ER positivity. It used to be 10%, and now it is only 1%. So it depends what definition do you get. You will end up with the figures between 65 and 75. As I've mentioned, the Herceptin actually story was a success story. Even in metastatic disease, the blue line is the Herceptin patients. And I think the red line, which is the ER positive tumors, their survival is improving. But if you look at this, ER positive tumor is still below the Herceptin curve, which is something new to us. We always thought in the late 90s that HER2 positive disease is a bad disease. But because we know how to treat it, it turns out to be a better disease now. So I think what we are living in the coming 10 years maybe is moving that red line up to be ahead of the HER2 of the blue line. And I think we have done some effort to that effect. This is our latest registry. So breast cancer is number one. You see some differences in the age-adjusted ratio between different countries. We were debating the other day whether 24.9%, i.e. 25 per 100,000 cases, is real representative of what we see. We feel that maybe we are closer to what's written in Qatar and Kuwait, which is about 45 to 40 to 50 cases per 1,000. These are small countries with excellent registries, and I think they have captured all their cases, and genetically I don't think we are different. So maybe we are still missing some in our cancer registry. We talk about stage in the registry, and unfortunately we still have only 1/3 of our patients have localized disease, and the rest is not. We talk about the histology subtype, which is good, but unfortunately we don't mention at all anything about types of breast cancer what we see in our cancer registry. So we don't know yet in our cancer registry how much ER positive, how much triple negative, and how much HER2 positive disease. And I think we should have this hopefully in future. Why is that? Because as you can see, hormone sensitive tumors is not only in hormone positive disease, HER2 negative. In HER2 positive disease, you might have some ER positivity as well. And I did not put it in the slide. Even in triple negative disease, now we started to test for AR receptors, the androgen receptors, which is again a hormonal therapy. And we can see few cases with AR positivity, and we need to learn how to treat these patients with hormonal therapy. So I think hormonal therapy can touch on all subtypes of breast cancer with no exception. Yesterday, we have seen from Dr. Abd Mohsen some talks about luminal A and luminal B, so this is not a new news. Luminal A usually is a low proliferating disease hormonal positive, and luminal B is more proliferative. These tumors are different from other cancers by the fact that they actually go to different sites. If you, for example, take brain mets, it's very low in incidence in luminal A and luminal B compared to HER2 positive disease. You know, in HER2 positive ER negative, it's 29%. In triple negative basal type, 25% compared to 8 and 11%. So, you know, it's different in behavior as well. It's not only, you know, in the way we treat them. And look at the bone mets, for example, in luminal A. Almost 70% will present with bone metastases, 70 compared to 39% in triple negative. To the contrary, there is more lung and liver in the other types. So again, we need to know our enemy very well in this case. The response to hormonal therapy is different. You know, luminals are not the same. In luminal A, compared to luminal B, responding to tamoxifen is also different. So we don't expect the same effect of hormonal therapy for these tumors. Again, when we talk about hormone-positive disease, there's 4 categories. You know, ER/PR positive, you get the best response, less in ER-positive, PR-negative. ER-negative, PR-positive, I'm one of the believers that this group actually does not exist. I don't think there's a tumor which is BR-positive and ER-negative. So it's important. And I think this is also important to realize that 1% of positivity in ER receptors qualify for what we call hormone-sensitive disease. And there was a lot of talk about why did they cut down from 10% to 1%. One of the explanations that although 99% of the cells will not have the ER signaling, if you disturb the 1%, you disturb the intertalk between the whole cell population and you end up with some activity. But that activity is never the same. This is, I think, an important statement here that strength of ER expression is important. It's important for prognosis and it's important for outcome of therapy. So we have, I think, to keep that in mind when we prescribe hormonal therapy. If I see a patient with ER positivity 90% plus 3, it's not like 5% plus 1 or plus 2. We know that, although they are both hormone positive tumors. Again, when we treat a patient with metastatic breast cancer and hormonal or ER positive disease, what I'm trying to achieve, the patient, of course, always will think about life, improving his survival. We should have the same goal, but we always know that really we cannot cure these patients. We know that, yet unfortunately we cannot say this. So we need to really maximize their quality of life and life as possible and try to give the best treatment with the least side effect. And that's why you see in the clinical trials the outcome varies from response rate into time to treatment, progression, overall survival, and quality of life. All these are important to us as clinicians. You have been through history as well. Yesterday, we know that the hormonal therapy in the first 50 years there was nothing, just oophorectomy, surgical estrogen deprivation, which was followed in 1975 with aminoglutathione, the first medical estrogen deprivation. Then aromatase inhibitors came along, and the receptor blocking of receptors through stilbestrol initially with very high dose, tamoxifen later on, and most recently fulvestrant, which a drug I think will really change a lot of what we do currently in breast cancer, and I'll talk about it more than other drugs. So this is more busy slides, showing us there was a lot of changes in the last 10 years when it comes to hormonal therapy, whether alone or in combination. Again, this is some history. We moved from no adjuvant therapy into adjuvant therapy with more than a drug, aromatase and tamoxifen, and now in metastatic we have many options. just a little word about tamoxifen and fulvestrant. Both are androgen receptor blocking agents, but the tamoxifen is a partial inactivation or inactivating drug to the receptors of AF1 active, and AF2 becomes inactive, while fulvestrant actually deactivate both subunits of estrogen receptors. So there is no transcription of the tumor cells at all. It actually binds, block, and accelerate degradation of the estrogen receptors, which is very interesting. On the other hand, aromatase inhibitors block the production of estrogen through either steroidal or non-steroidal compounds. Anastrozole, letrozole, and exemestane are the ones we are familiar with. These are the response rate to these medications in general. And as you can see, between oophorectomy and tamoxifen, there is no difference. Even in the last 70 years, we did not see really any great difference in the way we treat breast cancer. Till the aromatase inhibitor third generation came, the response rate jumped to 40 to 45%. Recently, we started to see the figures of 50 and 60% with fulvestrant in a response rate. So one can ask, what is the difference between tamoxifen and medroxyprogesterone or aminoglutathione? The main difference was why this drug was used is the side effect and the easiness of use. It's not actually the response rate, it's not the effect on survival. It became the standard of care because of side effects values, while in the new medications, whether the third generation aromatase inhibitors or the estrogen receptor down regulators, having, as I'll show you, better outcome. Now, one always asks himself, shall I give chemo, radiation, or hormonal therapy? And this is a slide to encourage you to consider hormonal therapy for ER positive, PR positive disease. You have a good response rate, and in HER2 status, again, if you have HER2 negative disease, you get good effect with hormonal therapy, whether you use tamoxifen or aromatase inhibitors. But if you have hormone HER2 positive disease, maybe the aromatase inhibitors are better than tamoxifen, and this is being the sort of the recommendations is to consider using aromatase inhibitors with Herceptin if you are going to consider it in HER2 positive disease. So HER2 positive disease is not always an indication for chemotherapy. That's, I think, an important message we need to keep in mind. Now, when it comes to the guideline, I think this is a slide summarize what we do in our daily life. And what I'd like to point out that, when we choose hormonal therapy, we go first, second, and third line, provided there is a response to what we are doing. So if you start the first line hormonal therapy and you see no response, it depends. If you really see progression while you are giving, then I think you should move straight to chemotherapy. If you see some response and then there is a progression, you consider second line hormonal therapy and so on. But always please remember to go back to chemotherapy when you feel the response is not there. It's very important. So although we are sort of pushing first, second, and third line, and even in the most recent guidelines I'll show you, you can consider fourth line and trial basis if it's available. Always keep in mind that chemotherapy is there. On the other hand, if you have given a patient chemotherapy, you can always go back to hormonal therapy. So it is an interchangeable situation according to a patient progress. Last guidelines, as you can see, importantly, they did not differentiate between HER2 negative and HER2 positive disease. Very important point. In both situations, they actually classified whether a patient had prior endocrine therapy within a year or no endocrine therapy within a year. And the difference is very clear. If it is within a year, then if premenopausal, you make them postmenopausal and you treat as postmenopausal. If they are postmenopausal, you go for ovarian, for aromatase inhibitors or selective. These are the options for listed. So for postmenopausal patients, non-steroidal or steroidal, or exemestane plus Afinitor, or fulvestrant, or tamoxifen, megasterol acetate, estradiol, and progesterone as well. So the only, I think, one which they have put level 1 evidence to is exemestane everolimus, but I think fulvestrant is coming into play as well. Aromatase inhibitors are the standard of care so far. The same has been mentioned by the most recent ESMO guidelines. They have actually, this is for postmenopausal aromatase inhibitors, and they included fulvestrant high dose as an option. And the addition of everolimus to an aromatase inhibitor as a second line has been put with it is bronze and cones with 1B level of evidence. What was noticeable is actually 100% of the voters have voted for this as a second line with this level of evidence. Why fulvestrant is a different drug as you know, as a pure anti-hormonal therapy? I'm not saying it should be used alone in future, but this drug has been compared to tamoxifen and estradiol in the first line and second line with the 250 milligram, and there was no difference. So it's an active drug in that setting, not less than the others. When the dose was increased to 500 milligram, and remember, we always use hormonal therapy with fixed dose. Tamoxifen fixed dose, anastrozole fixed dose. So we don't have a drug in hormonal therapy with a dose response curve. I don't want to go into the preclinical data, but this is a very clear clinical data to show you that this is the only hormonal therapy where when you increase the dose, you get a survival advantage. And this is the only hormonal therapy which have given survival advantage in the metastatic setting. So it's a very interesting story, actually, that the same drug, when you increase the dose, hormonal therapy, you get better overall survival and PFS in the second line setting. So they have started a phase 2 trial, randomized as a first line compared to the standard treatment, which is anastrozole, in the first study, which was recently reported. And look at this. The hazard ratio is 0.66 with a p-value is 0.01. Clear separation from the beginning, from the starting of the curve. The separation is there, and it was almost maintained. And look at the median survival, almost double. One of the questions was, is it because because of the new drug being good or the old drug doing badly? And this is the answer to this one. If you look at the exemestane, letrozole, anastrozole median survival in all the preclinical, all previous studies, the median survival was 8.5, 9.4, 9.1. In this study, the anastrozole did 13.1 median survival. So the control arm have done very well. And in spite of that, that drug has actually doubled the median survival. So I think we are looking into something genuine here.
I think that is a median time to progression rather than survival.
Yes. Sorry, yeah. The overall survival, again, through the same study, is 54 in the fulvestrant versus 48.4 with hazard ratio of 0.7 and significant p-value. So it improved BFS and overall survival in a phase 2 randomized study in all subgroups, and that was the same. So that is why this study is running as a phase 3 to confirm the phase 2 data. And I think we are waiting for this study to be reported soon. So that is touching on the first line endocrine therapy. We know that aromatase inhibitors for postmenopausal are the case. Is it going to remain the same? I think it's going to be changed soon. My feeling that fulvestrant will be a better drug to use in this setting, but we have to wait and see. Now, what about combining hormonal therapy with the biologics? And I think this is the second, this is what's going to push the red line up. It's not the hormonal therapy alone, it's combining hormonal therapy with something else. And we have seen, the mTOR pathway blocking by Bolero-2 primary survival data. When exemestane was used with Afinitor, the probability of event here has improved from 4.1 months to 10.6 months with a significant p-value. Again, a very important concept. Adding biological therapy to hormonal therapy improved the result. And this was evident across all the subgroup of patients, but the main issue was the toxicity of this compound. So I think we need to learn how to deal with these toxicities, and yesterday there was some talk about it. It's a big topic, but I think it's very important to know that these sort of biologics are here to stay. Last thing is the new biologic which is coming, which is the CD46 checkpoint inhibitors have been shown. Again, look at this separation between the curves. From the very early on, you see an excellent separation in the Paloma trial when you add letrozole to palbociclib. Our feeling also that this separation in lines will be proven in a phase 3 trials, and I think it will change the face of the way we look at treatment of hormone-sensitive disease. And genomic medicine being possible now is going to change the landscape of the way we treat. And the take-home messages to me, the outcomes are different for AR-positive breast cancer from other tumors. The original precision, personalized, targeted as one size does not fit all is actually applied to hormonal therapy as well. So we need to look about the type of hormonal therapy you are going to use according to age and molecular profiling of patients. We need to link anti-estrogens to other pathway, and I think this is what have shown very significant impact, and I hope we will see the application of this in the clinic, and I strongly believe that we will hear more and more as we learn much more about genomics in medicine. Thank you very much.
You are a great presenter and great communicator. So I think the floor is open for a few questions.
Putting the mechanism of action of fulvestrant in mind, so why fulvestrant was not tested in premenopausal females? I find no contraindication, though we don't have any single data in premenopausal. So this is number one. The second question about the Paloma trial, this medication got the FDA approval, but with a very weak evidence, phase 2 study. So tomorrow, if you have a patient in the clinic, are you going to prescribe this medication, or will you be waiting for the phase 3 data?
Okay, I respond to the first one. I think you are absolutely right. I think this drug will be for both pre and postmenopausal.
We don't have data, so this is the issue.
Yeah,
The company is not.
Yeah. But methodologically and the way it's like tamoxifen is a better tamoxifen. That's fulvestrant. It's blocking the androgen receptors, so there's no reason why to use it in fulvestrant. I think they are considering using it. It's a long story. Fulvestrant has been on for 25 years. It started, then it was dead because the 250 was similar to everything. People were working about dose response curve, and they have proven that there is dose response effect from 1995. And I don't know why the company did not push till recently the 500 milligram. And maybe we will see that 750 might do better even. Okay, so there's some studies on 750. That drug is unique in that regard. So I strongly believe that it will be in premenopausal as well, but we have to wait. The second point about, I'm a great believer of concepts of medicine. When you see a curve like this with a good, biological explanation, I'm not going to use it like this. I'm going to use it in a clinical trial. We have already, applied to participate in any clinical trial involving palbociclib. So I'm quite happy to put patients on these trials, but we have to wait for evidence to use it routinely. So yes, we will use it in a context of a clinical trial, being part of a national trial.
Because the data of PARP inhibitors before was very exciting in the phase 2, and then in phase 3 it came negative.
But PARP inhibitor was not PARP inhibitor at the end of the day, as they have said. So maybe it's a different story. I mean, CD4, look, there's two compounds. Both of them are proven to be very good. Again, so I think mTOR inhibitors, CD4 checkpoint inhibitors are here to stay, and we will learn more about it. Dr. Abul Khair.
Thank you, exciting as always.
Thank you.
If you have metastatic breast cancer, postmenopausal, AR negative, BR positive, bone mix. So what is
ER negative?
BR positive, postmenopausal, and no visceral mets. So what is your choice?
I don't believe the pathology, personally. I don't believe there is
So why?
something. I have spoken to eminent pathologist, Michael Dowsett at the Master. We went through this a lot. Biologically, that entity should not exist.
So what is your practice? What
I
do
go,
you- what
I
do you
go
give?
for Xeloda. I treat it as ER/PR negative. I really don't count on PR positivity in ER negative disease. Your hormonal therapy is addressing androgen receptors, not progesterone receptors. So to me, it does not make sense, and I don't count it. I go for Xeloda or whatever I'm going to use. Yeah.
In a young premenopausal patient, only bony metastasis, ER/PR positive. So we started treatment with the Zorodex plus tamoxifen or Zorodex or Ermidex.
Okay, I have few of them now, actually, in the last year, and I started sort of a new policy with them. If they have completed their family, I really strongly advise them to have surgical oophorectomy. And I've managed in 5, almost, the 5th is in the way, waiting for. To me, it's a permanent ovarian ablation, which she will need. I know for sure she will go into postmenopausal stage. She will sort of save money and time coming to the hospital and having an injection every month. If she does not accept that, and some of them they don't, especially the very young. I'm talking about people, patients who are 40 plus. Most of them have completed their family and they have metastatic disease, so they go for that. So if not, we will go for LHRH and aromatase inhibitors or exemestane. You can do that as well. Now, for a patient who had stopped tamoxifen for a very long time,